We continue with the somatoform disorders, and this time we want to look at hypochondriasis. Hypochondriasis is an unrealistic preoccupation with the fear that one has a serious disease, also called disease conviction, or will get a serious disease called disease phobia. The Diagnostic and Statistical Manual 4 suggests that this fear arises out of unrealistic interpretation of physical signs and sensations. The fear becomes disabling and persists despite appropriate reassurance that no organic pathology can be detected. Occasionally, medical disease may be present, but in the hypochondriacal individual, the symptoms are grossly disproportionate to the degree of pathology. The preoccupation may be with a specific organ or disease, example, cardiac disease, with bodily functions such as peristalsis or heartbeat, or even with minor physical alterations such as a small sore or an occasional cough. Individuals with hypochondriasis often have a long history of doctor shopping and are convinced that they are not receiving the proper care. Preoccupation with the fear of serious disease may interfere with social or occupational functioning. However, some individuals are unable to function appropriately on the job while limiting their physical complaints to non-working time. Individuals with hypochondriasis are so totally convinced that their symptoms are related to organic pathology and are often irritated by any implication that stress or psychosocial factors may play any role in their condition. How do we diagnose an individual suffering from hypochondriasis? The preoccupation with fear of having, or the idea that one has a serious disease based on the person's misinterpretation of bodily symptoms. The preoccupation persists despite appropriate medical evaluation and reassurance. The preoccupation causes clinical significant distress in social, occupational, or other important areas of functioning. The duration of the disturbance is at least 6 months. How do we nurse a patient suffering from hypochondriasis? Monitor physicians' ongoing assessment and laboratory reports. Identify times during which preoccupation with physical symptoms is worse. Determine extent of correlation of physical complaints with times of increased anxiety. Client is unaware of the psychosocial implications of the physical complaints. Knowledge of the relationship is the first step in the process of creating change. Convey empathy. Let client know that you understand how a specific symptom may conjure up fears of previous life-threatening illness. Help client determine what techniques may be most useful for him or her to intervene when fear and anxiety are exacerbated. Example, relaxation techniques, thought-stopping techniques, physical exercises, etc. All of these techniques are effective to reduce anxiety and may assist clients in the transition from focusing on fear of physical illness to the discussion of honest feelings. Encourage clients to discuss feelings associated with fear of serious illness. When the client can express feelings directly, there is less need to express them through physical symptoms. Let's continue with the nursing care. Encourage clients to participate in decision making regarding care as well as life situations. This offers the client some feeling of personal control and decreases feelings of powerlessness. Ensure that client is not becoming increasingly dependent. Withdraw attention at times when client is focusing on physical symptoms. Independent functioning increases feelings of self-worth. Lack of reinforcement may help to extinguish maladaptive behavior. Offer positive feedback which clients respond to stressful situations with coping strategies, other physical complaints. Positive feedback enhances self-esteem and encourages repetition of desirable behaviors. So these are the nursing interventions when an individual is suffering from hypochondriasis. So we'll move on to the next somatoform disorder called body dysmorphic disorder. Body dysmorphic disorder, formerly called dysmorphophobia, is characterized by the exaggerated belief that the body is deformed or defective in some specific way. The most common complaints involve enlarging or slight flaw of the face or head, such as wrinkles, scars, excessive facial hair. Other complaints may have to do with some aspects of the nose, ears, eyes, mouth, lips, or teeth. Some clients may present with complaints involving other parts of the body, and in some cases or instances, a true defect is present. So in body dysmorphic disorder or in dysmorphophobia, in some cases, a true defect is present, but the individual exaggerates it. However, the significance of the defect is exaggerated and the concern is grossly excessive. Social and occupational impairment may occur because of the excessive anxiety experienced by the individual in relation to the imagined defect. The person's medical history may reflect numerous visits to plastic surgeons and dermatologists in an unrelenting drive to correct and the imagined defect. He or she may undergo unnecessary surgical procedures towards this effect. The etiology of body dysmorphic disorder or the cause is unknown. In some clients, the disorder is attributable to another pervasive psychiatric disorder such as schizophrenia, major mood disorder, or anxiety disorder. How do we treat an individual suffering from body dysmorphic disorder or dysmorphophobia? Assess client's perception of his or her body image. Keep in mind that this image is real to the client. Assessment information is necessary in developing an accurate plan of care. Denial of the client's feelings impedes the development of a trusting therapeutic relationship. Help clients to see that his or her body image is a disorder or that it is out of proportion in relation to the significance of an actual physical anomaly. Recognition that a misperception exists is necessary before the client can accept reality and reduce the significance of the imagined defect. Encourage verbalization of fears and anxieties associated with identified stressful life situations. Discuss alternative adaptive coping strategies. Verbalization of feelings with a trusted individual may help the client come to terms with unresolved issues. Knowledge of alternative coping strategies may help the client respond to stress more adaptively in the future. Involve clients in activities that reinforce a positive sense of not based on appearance. When the client is able to develop self-satisfaction based on accomplishment and unconditional acceptance, significance of the imagined defect or minor physical abnormality will diminish. So this is what we call body dysmorphic disorder, and these are the nursing interventions that we give to them. Now let's look at the causes of somatoform disorders in general. So etiology of somatoform disorders. They are genetic or hereditary. Studies have shown an increased incidence of somatization disorder, conversion disorder, and hypochondriasis in first-degree relatives, implying a possible inheritable disposition. Biochemical. Decreased levels of serotonin and endorphins may play a role in the cause of pain disorder. Serotonin is probably the main neurotransmitter involved in inhibiting the firing of efferent pain fibers. The deficiency of endorphins seems to correlate with an increase of incoming sensory pain stimuli. The psychodynamics. The psychodynamic therapy of conversion disorder proposes that emotions associated with a traumatic event which the individual cannot express because of moral or ethical unacceptability are converted into physical symptoms. Some psychodynamics view hypochondriasis as an ego defense mechanism. Physical complaints are the expression of self-esteem and feeling of worthlessness, because it is easier to feel something is wrong with the body than to feel something is wrong with the self. Another view of hypochondriasis as well as pain disorder is related to the defense guilt. The individual views the self as bad based on real or imagined misconduct and views physical suffering as a deserved punishment required for atonement. And that's why it's a psychiatric condition. Now, we want to look at the somatoform related disorders, because we have finished looking at the somatoform disorders. Now I want to look at the somatoform related disorders. Remember that the somatoform disorders are the anxiety related disorders. Now somatoform disorders also have related disorders, and let's look at that. Somatoform disorders need to be distinguished from other body-related mental disorders such as malingering and factitious disorders, in which people feign or intentionally produce symptoms for some purpose or gain. In malingering and factitious disorder, people willfully control the symptoms. In somatoform disorders, clients do not voluntarily control their physical symptoms. So this is the difference between somatoform disorders and the somatoform related disorders. The somatoform related disorders are malingering and factitious disorder. And we are saying that in somatoform disorders, the symptoms are not controlled by the individual. It is not fake, it is not intentional. But in malingering and factitious disorders, the symptoms are willfully controlled. Malingering. Malingering is the intentional production of false or grossly exaggerated physical or psychological symptoms. It is motivated by external incentives such as avoiding work, evading criminal prosecution, obtaining financial compensation, or obtaining drugs. That is malingering. People who malinger, however, have no real physical symptoms or grossly exaggerated, relatively minor symptoms. People who malinger can stop the physical symptoms as soon as they have gained what they wanted. They avoid medical procedures. When exposed, they may angrily give up their symptoms and sign out from the hospital. So let's look at the next somatoform related disorder called factitious disorder. It is also called Munchausen syndrome. These patients or patients who suffer from Munchausen syndrome or factitious disorder also knowingly fake symptoms, but do so for unconscious psychological reasons that become evident after a thorough psychiatric evaluation. They are usually loners with an early childhood background of trauma and deprivation. They are unable to establish close interpersonal relationships and are generally have severe personality disorders. Unlike many malingerers, they follow through medical procedures. Although factitious disorders are uncommon, they occur most often in people who are in or familiar with medical professions such as nurses, physicians, medical technicians, or hospital volunteers. A variation of factitious disorder, Munchausen by proxy, occurs when a person inflicts illness or injury on someone else to gain the attention of emergency medical personnel, or to be a hero for saving the victim. An example would be a nurse who gives excess intravenous potassium to a client and then saves his life by performing cardiopulmonary resuscitation. Or another example is a diabetic patient. The nurse gives the diabetic patient excess insulin, and therefore the patient goes into coma. And when everybody rushes there, he comes to give the patient perhaps 50 milligrams bolus of sugar intravenously and revives the patient and becomes a hero. That is what we call Munchausen by proxy. It's a variation of factitious disorder. People who injure clients or their children through Munchausen by proxy generally are arrested and prosecuted in the legal system. Both factitious disorder and malingering can be difficult to distinguish from the somatoform disorders and from organic illness, yet careful and repeated examinations will usually uncover the deception. The most common presentations include abdominal pain. If it's the heart, there are complaints of pain, may induce arrhythmias, a variation from the normal rhythm in the heart's action with digitalis, or produce tachycardia with amphetamines. Bleeding, that is, patient may take anticoagulants or add blood from a scratch to lab samples. Neurological, there may be weaknesses, seizures, unconsciousness, difficult to differentiate from conversion symptoms. Fever, produced by manipulating the thermometer, example, hot coffee in the mouth. Although they both produce symptoms consciously, they should be dealt with differently. The malingerer should be handled formally and often legally. The patient with a factitious disorder should be treated sympathetically and every effort made to convince him to enter psychotherapy. The next thing we are looking at is what we call Ganser's syndrome or prison psychosis. Ganser's syndrome, though classified as a dissociative disorder or not otherwise specified, is usually considered a variant of malingering. It is generally associated with prison inmates who want to avoid punishment. Ganser's syndrome is an intentional production of psychiatric symptoms. Symptoms usually do not resemble any known diagnostic entity. Patients display exacerbation of symptoms when they are being watched. Recovery is sudden, and patients typically claim to have amnesia for the symptomatic episode. So in this session, we have looked at the somatoform disorders. We have also looked at the somatoform related disorders, and we have looked at variations of the variation of Munchausen syndrome, and we have ended with Ganser's syndrome. These are the references. Get it and read more and know more for yourself. Thank you.